But so pancreas, these biopsy tissues mostly by EUS, preferably with core needle over FNA to get more of the architecture. Is if possible, ERCP versus CT guided can be done as well, but those are used less commonly and have lower yield, especially the ERCP. Okay, so walk us through the histology that you see for normal, and then we also have some IPM in here.
Yeah, exactly. So over here on the left is going to be kind of your normal histology. Centrally, we have kind of a nice normal pancreatic duct. It's going to be very similar to your bile duct. So kind of this
Yeah.
low cuboidal epithelium, basally located nucleus, all the same size. Out on the periphery, we have kind of our acinar cells. So that's the typical organization of the pancreas. These are the ducts that are going to be affected by things like IPMN or PANN, which is pancreatic intraepithelial neoplasia. What you have here on the right in these two images are examples of IPMN or intraductal papillary mucinous neoplasm. And so these are basically going to be a neoplastic process that grows along the duct surface. So again, not an invasive thing, but almost like a pre-neoplastic
Yeah.
condition. Um, they are graded based on cytology and architecture. You have a low-grade version over here on the right. Again, abundant mucin kind of at the surface of these cells, and then you'll have kind of the smaller nuclei that are predominantly at the base of the cells again. Over here, again, when you think about it, almost like when we were talking about colonic adenomas, this
Hmm.
is going to be a lot darker. The architecture can start to get a lot more complex with kind of a little bit of honeycombing and disorganization. All of your nuclei are disorganized, so you can see that they're not just at the base of the cell anymore, but they extend all the way up to the lumen, basically. IPMNs are things that you can see grossly, so it should be
I
visible
see.
to the naked eye, right? So that's going to be something that's about zero point 0.5 centimeters or bigger in size, usually seen on imaging. And it can affect the main duct or the
Hmm.
branch ducts.
Got it.
Whereas Pannin is something that's usually microscopic, so a little bit different.
All right. Yeah, let's talk about these invasive histologies, and I have an example of PNI here as well.
Exactly. And so when we think about Pannin and we think about IPMN, those are preneoplastic processes. And they're limited, like we said, to the duct itself, right? So when we start to see adenocarcinoma, that's going to be these ducts that kind of extend either beyond the basement membrane of our original duct or really decimate basically the architecture of the normal pancreas. And so as we look at these two images you have here up on top, we don't see any acinar parenchyma. We don't
Right.
see kind of our normal duct structure. So
Very
that's
different.
been obliterated. Yeah. They're graded pretty much similarly the way we do most GI tumors. So again, the percentage of lumen
See,
formation kind of
right.
determines
There's here in the well depth, there's a lot more of the white lumens versus,
exactly.
and then
Exactly.
on the one on the right would be moderately differentiated, kind
So
of,
this
sort of.
one is probably starting to get more poorly
Okay.
differentiated. And I say that because even though we still have lumen formation, what we
Yeah.
see is a lot of single cell infiltration. And so that is another sign
And what
of
is
poor
that? What is
differentiation.
single?
So instead of having nice ducts form, the lumens that we're seeing are actually in the cytoplasm
Oh,
of
I
the
see.
cells
Okay.
themselves. And we have
Got it.
just
Got it.
individual cells that are kind of infiltrating.
Got it. Got it. Cool.
And then they do have a propensity to grow along nerves. And so that's what you have kind of down here in this bottom image. We have a nice adenocarcinoma gland wrapping around this neural
Huh.
tissue
Okay.
within
That's
the
cool.
center. Oops.
Well, not cool, but that's because that's something we talk about with regards to risk of local recurrence,
Mhm.
and sort of the way they spread along the vessels is through perineural invasion. So it's cool to be able to see that.
Yeah, it's I've had cases on frozen section that are really challenging where, we're looking at bile duct margins that are completely negative. But if you look at the tissue around the periphery of that bile duct, it'll be growing up the
Interesting.
nerves. So sometimes that's the only place we actually see it in those frozens.
Okay, molecular markers. This seem right. TCK7 positive, 20 negative.
Exactly. So it's similar to cholangiocarcinoma. It's going to be
That's right.
7,
That's right.
19 positive, 20 negative. There's not a lot, specific for pancreas cancer. Again, it'll stain identically to like a cholangiocarcinoma. We can use certain markers like SMAD4 when we see loss of SMAD4 or positive staining with IMP3 that can help us distinguish kind of reactive chronic pancreatitis type glands from invasive adenocarcinomas, which can be crucial when we get those small FNA specimens or core biopsy specimens. So that can be helpful.
Got it. And I just listed here for stage 4, these patients are all recommended get NGS, and there's sort of a large range of mutations, fusions, amplifications that we're testing for. Okay. This is something I've always wanted to know more about is, when you get a Whipple specimen, how are you looking at the margins? What is the process for analyzing that? Because obviously in pancreas cancer, the margins are such an important part.
Right. So these are obviously very complicated specimens. And so we do have to take great care when we're evaluating the margins. Typically, we're going to be looking at proximal and distal margins, which are usually stomach or gastric margin and a duodenal margin. And then those that kind of fall more around the pancreas. And so things that we look for would be common bile duct. Here you can see it as it entered
Oh,
kind of the
okay, I see.
superior aspect of the pancreas. So over here is stomach, right?
Yep.
Down,
Appendix.
oops, I am sorry.
Okay.
Down here, we're making our way to the ampulla, and then further on is the duodenum. And so back behind the duodenum is sitting the pancreas.
Huh.
So this
Okay.
is the superior aspect of the pancreas. That's where the common bile duct comes out. So we evaluate that. On This is looking at the specimen from the posterior aspect.
I see.
Okay, so duodenum over here, stomach over here. This is the pancreas
Yep.
itself. This is going to be the pancreatic neck margin that's inked in
I
black
see.
here.
Okay.
That's where pancreatic duct will be. Over
I
here is
see.
the retroperitoneal margin. So it's like kind of this little roughened area that it'll often have Cautery artifact too, where it's surgically kind of removed from the body. So that will be inked out here in green. And then this area here that's really kind of smooth is the vascular groove area. And so
Oh, very
that's
interesting.
where it
Okay.
sits kind of on top of the mesenteric
I
vessels.
see.
So a lot of recurrences happen there, even though
Yeah.
it's not traditionally considered a margin. And so we ink that and we evaluate that also.
Got it. Got it. So I guess, but even before you open up the specimen, you're kind of dividing into those 3 parts.
Yeah, so we're inking all of these and marking
Okay.
them out beforehand.
Oh, that's really cool.
And then there are different ways that you can kind of open these specimens, but basically I think the long and the short of it is you really want to make sure that we get nice sections that go through the ampulla and
Hmm.
here the papilla of Vater to make sure that we are ruling out things like ampullary tumors. We want to cut through sections that include the intrapancreatic portion of the common bile duct because we can also get distal cholangiomas that happen in these Whipple specimens. And then making sure that we see kind of the main pancreatic duct as it kind of comes through the pancreas and kind of meets that common bile duct to kind of form the ampullary channel. And so we look at all of that. So our diagnosis of the tumor type is really done mostly at the time of gross inspection,
Right.
localizing where the bulk of that tumor is originating and kind of doing it that way. Because as we've mentioned earlier, when we get to the microscopic portion, all of these tumors pretty much stain similarly. So
Right.
there's not a great way for us to differentiate it that way.
And just out of curiosity, from when you get the specimen to when you report for pancreas cancers, how long is that whole process of all these steps?
Usually it'll take a couple days, so 2 to 3 days.
Okay.
But if we run into problems where we either need more sections to make sure we're ruling out cholangio versus pancreas or
That's
things
right.
like that, it can take additional time. If the patients have been treated, sometimes we have to do additional sampling to make sure we're looking at the entire tumor bed or that we're getting an adequate kind of lymph node dissection because the radiation and chemo can really shrink down the size of the lymph nodes. So it can be a lot harder to find.
Got it. Oh yeah, now the lymph nodes, they're all in this specimen too.
They're all in the specimen too, and they can be very tiny. So a lot of this kind of
So how do you look
fibrous,
for them?
filmy tissue.
Like by palpation?
They do by palpation, but in the pancreas, they can be very tiny. And so all this filmy tissue that surrounds the pancreas actually gets stripped off and submitted,
I
and we
see.
look for microscopic nodes. And then there's a great lymph node packet that exists in between the pancreas and the duodenum in that
Uh-huh.
pocket there, in that paraduodenal groove. A lot of lymph nodes kind of will sit in there as well.
Cool.
Other things I would say is, like I said, we do receive some of these after neoadjuvant treatment.
Hmm.
And so that can also, like we've talked about before, be difficult for evaluation. A lot of times we'll have a big tumor bed grossly, but if you look at it microscopically, only a little bit of tumor exists. And so
I see,
in the
yeah.
updated AGCC, it's all size-based criteria for doing the pathologic staging. And so all that will be based on microscopic measurement
Got it, got
of
it.
viable tumor.
And I obviously have to ask as a radiation doctor, but if you see a patient after they've gotten, say, SBRT or high dose radiation, does the specimen look different? Is it more fibrous? Is it more, you know, tough, or is it? you
It,
know?
it can be. I mean, a lot of times patients will get chronic pancreatitis anyway if they have a big mass kind of in the
Right.
head of the pancreas. But we do see some changes in the vessel. We'll get some fibrotic changes around the vessels
Okay.
and things like that. And a lot of times it will look similar because, because of the type of tumor this is, it does induce its own kind of fibrotic,
Right.
yeah, tumor stroma. And so it already kind of looks scar-like, I
Yeah.
think, in its original state. And then after treatment, of
There
course,
might
we
be
see,
pain.
yeah.
Got it. Very cool.